I'll now introduce our faculty. Beverly Gorman, RDCS, Retired Director of Accreditation, Echocardiography, Intersocietal Accreditation Commission, IAC. And Jessica Stout, BS, RDCS, ACS, FASE, Technical Director, Echocardiography Laboratory, Beth Israel Deaconess Medical Center, Boston, Massachusetts, and Maria Stanzik, MS, RDMS, RVT, RTRM, Assistant Professor and Vascular Sonography Clinical Coordinator, Thomas Jefferson University, Philadelphia, Pennsylvania. Maria.
So welcome everybody. The co-presidents of ICUS and the board of directors are so thrilled to have you join our webinar today. And I would like to share with you some information about ICUS. ICUS is a global professional society. We have members that are in 60 countries, and they are comprised of a diverse group of physicians, sonographers, nurses, scientists, industry, and patients themselves. So ICUS is free to join and nothing is free. So join ICUS. Membership is free. All CME webinars are free. Everything education related is free. So feel free to scan the QR code to join ICUS today. The commitment of ICUS is twofold, one of which is to promote the safe and effective use of contrast-enhanced ultrasound agents. The second is to provide free contrast-enhanced ultrasound education. What you will have available to you on the ICUS website is the case of the day. So there are various interactive tools, images, quiz, teaching points that you can share among your colleagues as well as your sonography students. There is also the training hub, and the training hub is divided into two components. There is a cardiac component as well as a general sonography component. And you can have contrast, all things contrast at your fingertips with the ICUS Connect. So you can download this. This is compatible with Apple and Android devices. So again, feel free to scan the QR code for additional information. Being a member of ICUS, you will receive a news monitor that will provide you information about the latest, greatest things and new trends and new developments involving contrast. And we encourage you to explore the ICUS website. And again, scan the QR code to join ICUS. We are happy to have you as part of our bubble community. We would like to thank our sponsors for their continued support in providing free education. And this is today's agenda. So with that, I am going to pass it over to my colleague, Bev.
Thank you, Maria. Thank you, everyone, for joining us today. I think you'll find the next hour or so, you'll pick up a few pearls of wisdom along the way. So next slide. Here we are, we're all cleaned up and happy. Next slide. I have no disclosures. So the objectives for today's webinar are to understand the importance of the role of contrast-enhanced ultrasound and sonography programs, to review the benefits of IV training for sonographers, to discuss the inclusion of contrast ultrasound in current education curriculums. Next slide. So I just wanted to start by pointing out some of the obvious things, but it is one of the most valuable tools a sonographer can have and use. It benefits not only the sonographer, the interpreting physician, but most importantly, the patient. So CEUS provides a high quality, reliable diagnostic images, next, and can save one of those horrible suboptimal, technically difficult study and significantly improving the interpretability of the study. And there's no radiation and no dye, so another bonus there. So all in all, it improves diagnosis, saves lives, providing quality patient care. And as I think we go into this, we need to realize all the benefits of contrast, not only to the sonographer, not only to the interpreting physician, but to the patient. And I'm going to get on the next slide into some of the improvement in workflow. And again, it's not just for the sonographer or just for the interpreting physician, it's for the patient most importantly. It reduces the need for repeat ultrasound studies. And I know from past experience, this is one of the biggest complaints of interpreting physicians and hospitals and even doctors' offices, that they have to repeat ultrasound studies that were done elsewhere or done 2 or 3 weeks ago and didn't get adequate information. So again, it reduces a lot of those repeat studies. It also can eliminate the need for downstream tests such as CT, angiography, things like that. So what does that do? That reduces the time to diagnosis. It's immediate. You know, the physician can be sitting in the other room and reading the study, so the patient doesn't have to wait 3 or 4 days for an interpretation. It's done immediately. It reduces wait times for patients who receive contrast. There's nothing more frustrating to get your patient in the room, get them all ready to go, and you can't get the images that you need. So then you have to stop what you're doing, get a nurse, wait, and this just eliminates all of that. Next. And it's portable. You can take it to the ICU, CCU, wherever you need to go, and do your study, get your images. And you sure can't do that with CT or angiography or nuke medicine. So again, it's a time saver and a money saver, really, because those are those downstream tests that you would normally have to perform if you don't use contrast enhanced ultrasound. It reduces the scan time, and this you think, oh no, it adds time. Well, it really doesn't, because if you're the sonographer, you start the IV, you give the contrast, you're not struggling for 5, 10, 15, 20 minutes to get that image and hurting yourself. A lot of times that's when patients or sonographers will get injured, when they have large patients, which now more frequently we're seeing. You give the contrast and you get the images that you need. So the sonographer administration of contrast can be expanding role for sonographers and with improved overall outcomes. I can tell you that a sonographer who can start their own IV and administer contrast, typically, especially in the hospital systems, is going to be paid higher. Many health systems and hospitals are starting tiered pay scales for sonographers. So if you come in and you're just a new sonographer, then you can develop those skills and you'll end up making more money. But again, it's not just for the sonographer. It benefits the sonographer, the reading physician, and most importantly, the patient. And with that, I just wanted to point out very quickly that our KHEP standards and guidelines do include IV insertion and injection of contrast. And so that's all I have for today. I will turn it back over to Maria.
Sorry about that. I just realized I was on mute, because why not? It's amazing how this many years into using Zoom and I still forget to unmute myself. But anyway, good morning again. So these are my disclosures, and I would like to take a moment to talk to you about the SDMS scope of practice. And the SDMS scope of practice really defines our roles and responsibilities as sonographers working within a healthcare team. So the scope of practice was recently revised, and that new revised scope was released in March of 2024, and you can access that. This is a link here, but you can access that on the SDMS website. ICUS was involved along with many other professional organizations. They were involved in that revision process. And the key elements that were included in the scope include the following: a sonographer's ability to place an IV, to administer a contrast agent, and to determine when contrast-enhanced ultrasound is necessary. And I just want to take a moment to talk about that last bullet point that was included in the scope. And if you think about it, our job, our role as sonographers are to manage and take care of our patients to the best of our ability. How many of us, when scanning, for example, an abdomen, we see something suspicious in the kidney, we notify the radiologist, we call and get a prescription. So truthfully, contrast should be managed in exactly the same way. So it should be no different than how we function on a daily basis. So with that, I am going to pass the baton over to Jess, who will talk to us about the importance of IV training, and then I will see you back here in just a few moments.
All right. Well, thank you everybody for joining us today. Again, my name is Jess. I'm the technical director here at Beth Israel in Boston. Here are my disclosures. So I'm going to talk a little bit about IV training, but I also always like to talk a little bit whenever I talk about the IV training and benefits of IV training. I always like to go into kind of the sonographer role in general, and talking about not only the importance of contrast, but how we can make our workflow better, both from an IV perspective and other things that we can do to kind of remove some of those barriers that we see day to day. So every time I talk about contrast, I feel like I always go back to this study because I think it's so impactful. And so this is a study that was done on cardiac patients. So I apologize. The first few slides I have here are very cardiac focused. So Maria, if you have anything from your side and you want to jump in and add it, please do. Just because I do work in cardiac and I know we have a lot of other folks on here. But I think the message is the same, but I do have a few cardiac slides here. So this study was done, and it really shows on the left, we have our studies that were done that were technically difficult. So a large majority of our studies that were technically difficult and even uninterpretable. And then we look to the right after we use our contrast, and our technically difficult studies dropped from 87% to just about 10%. And really in the surgical ICU, they had like no adequate studies. They were all technically difficult, uninterpretable. And there, almost 80% became adequate. So that is huge. From an image quality standpoint, we're now delivering, images that can be actually interpreted and used. So they took this study one step farther though, and they said, okay, well, now we have these studies that we can interpret and we can see better, but what does that matter? Well, they actually showed that using the contrast changed management in so many of these patients, and they resulted in avoidance of farther diagnostic tests in 33% of patients and up to 55% in the surgical ICU. And they actually changed management in up to almost 63% of surgical ICU patients. So I know we talk all the time about, oh yeah, downstream testing, changing management, but here it is, in this study, and they changed medications, they avoided procedures. And so our use of contrast in our labs is incredibly important. Despite this, we know that UEAs or contrast agents are very underutilized. And this is actually a study out of Beth Israel, and this was published in JACE in 2020. And what they found was that this is like almost 172,000 transthoracic echoes. And we were only using contrast in like 2.6% of these patients. And we know at the very least, we should be using contrast in our suboptimal patients. And we know that 10 to 20% of our patients are usually suboptimal. So we were very low in our usage. And even though we kind of crept up over the years and increased our usage a little bit, we still saw that proportionately, the number of suboptimal studies actually increased at a higher rate. So we really weren't keeping up with where we should have been from a usage standpoint. And Dr. Jordy Strom, who is our technical director here, he is also on the board of ICUS and very much a contrast advocate. So he updated this graph to kind of show, because the last one only went to 2018. We updated it to go through 2022 to kind of show the growth that we've had in the institution with the contrast implementation here. And you can see that we've really increased the use in the last few years to more proportionate to what we should be doing here in our lab. So why over the years, weren't we using enough? Well, because of all the barriers that we face day to day. And this is a trend survey out of the ASE trend survey from 2021. And overwhelmingly, people say that what is the top driver to increase appropriate use of ultrasound enhancing agents? It's the ability for sonographers to place IVs. And that was the top answer. And and right below that, the ability for sonographers to inject contrast. And then, on the right, what are the main barriers from preventing your lab from using ultrasound enhancing agents? And again, workflow issues, it's too much effort. They're not trained in the use and administration. So overall, just we're seeing again and again, workflow issues, sonographer training issues. So this is from Beth Israel. So I started here as technical director in early 2021. And at that time, our contrast use was between 3 and 12%. That disparity is outpatient versus inpatient. We know that for our outpatients, we have a lot more workflow barriers than we do for our inpatients who already have IVs. And so usage for inpatients is inherently higher because of that, and also because of the acuity of the cases as well. So the biggest workflow that we first faced was that our sonographers were not injecting, and Beth Israel itself is very geographically dispersed. Even on our main campus, we have like 5 different locations where we have sonographers. So we had one poor fellow that had to schlep across every campus and inject contrast. And it was just, they, believe it or not, the fellows had better things to do than inject contrast for us. And sonographers were waiting a really long time. And that really impacted their workflow, because we're busy, especially outpatients. We're on the hour and you don't want to get behind. And really the use suffered because of that. So the first thing we did was we made sonographers able to inject. And the second thing we did, which we're still working on now, is getting all of our sonographers IV trained. And we have about half of them, 3/4 of them now. And we're still working on doing that. So I'm interested to see kind of how the use will increase when we look at numbers from 2024 as we have more and more sonographers trained. Side note, the other things we kind of did here to kind of enhance our contrast use was kind of promote quality over quantity. Yeah, quality over quantity. So when I started here, it was very much numbers driven. Everyone was very worried about getting their numbers in every day. Like, I have to do my 7 echoes today. And for me as a director and also a sonographer, I would much rather have less studies that are really good quality and answer the question. Because ultimately, if you're doing 7 rush studies, some of those ends up, you have to repeat the next day or whatever. And I would just much rather everyone take their time and do good studies rather than just try to hit a number every day. And that's a big culture change for a lot of people. And that was kind of something big we had to overcome. We also try to do QA a little bit more with our sonographers. That tends to help a little bit. And from a physician perspective, I mentioned our director, Dr. Strom, is incredibly involved, supportive. He is very engaged at the sonographer level, and and that really helps. I always say that between the two of us, we're probably pretty insufferable because we both are huge advocates for contrast and quality, but it works because we're both, have the same goals and things like that. So first thing, really quick, sonographers injecting. If you are having issues implementing that in your institution, I would say don't reinvent the wheel here. So try to model this after other departments in your hospital where people that are non-nursing are already injecting meds or tracers, things like that. What we needed to do was get approval by our Med Exec Committee and our P&T, our Pharmacy and Therapeutics Committee. And essentially, we already had this policy written up within the system. It's just that cardiac sonographers weren't on that list, weren't included in the policy. And the policy says if there's no state licensing board, healthcare professionals who are employees that are certified or registered by a recognized professional association, and they have a published scope of practice, they can administer medications pursuant to the prescription or an order by a doctor. And so we have our organizations, we have this great new scope of practice. So we have everything that we need to say we should be included on this list of non-nursing staff that are allowed to inject medications. And in fact, we were added, and you can see here at the bottom, among the list of, MRI, nuke med, RT, even ophthalmology techs, they were doing eye drops. And so we were added, and now we're able to inject contrast. And of course, standing orders are always very helpful. I think a lot of people probably have standing orders now, but all of our contrasts have the verbiage, or I'm sorry, all of our orders have the verbiage with contrast, so we can use as needed and at our own discretion. Okay, I promise this is my last cardiac slide. This just for our cardiac folks, from a indication and policy point of view. I think there is a historic and an antiquated idea that we should be only using contrast in our suboptimal patients. And I think all of us had like this ingrained in us, like this 2 or more segments not well visualized, we should be using contrast. Well, great, absolutely. If that's the case, then we should be using contrast. But there are so many other situations where we should be using it as well that are beneficial to our patients and will change management for our patients. So I love this little chart from the auto textbook that Dr. Lindner did. And it shows that, yes, on the left, in our poor quality echoes, we know that for all these clinical indication, there's a very high benefit for contrast use. But even in our good quality echoes, there is still a really high benefit of use for some clinical indications. So our patients that are presenting with chest pain and you're looking for resting ischemia, our patients where we're ruling out LV thrombus, our patients where we're looking for LVEF before valve intervention or ICD, cardiotoxic chemotherapy. I mean, I could go on and on, but I think we just need to kind of shift away from this thinking of we're only using it in suboptimal echoes and realize that it can really change management in so many other clinical indications as well. We do have a set policy which describes all the indications of use where we should be using it. But again, it's at the sonographer discretion. And just a side note, there's a lot of policies like this on the ICUS website. So if you need like example policies or things like that, that is available on the website. So sonographer QI, we started doing monthly QI lunch meetings to kind of look at different cases and see where we can improve in contrast use. And I'm sure the sonographers only come for the food, which is fine, because it still gives us a chance to get together and decompress, go over studies. It's really a low, like it's just very easy, and we just review studies and go over things. And I think it's just a good time to reinforce different cases where we should have used contrast. We also get feedback from our physicians on our reporting software. So if a physician reads a study and thinks that we should have used contrast, they can indicate that, and then I can follow up with it and the specific sonographer. And the other thing we did is we started to track the percentage of contrast that each sonographer is using. And so this chart is from, I don't know, a few months ago, and it shows the number of studies the sonographer did and the percent of contrast they used. And it helps me see, trends or where people may need extra support or situations where we're not using it. And to nobody's surprise, the lowest numbers here at 3%, 7% are of course my full outpatient, clinics where we still are working on our IV support. So IV certification specifically, we know it's a great thing for us sonographers because it's an additional skill set for us. It improves our marketability, it promotes our teamwork, it improves our efficiency, and just overall decreases our waiting time day to day and has a really positive impact on our patient care and on our patient management. So how do we do this? Well, The first thing, again, don't reinvent the wheel. And I'll say that over and over again. You know, there's so many departments in our hospitals already that are doing this. So talk to, you know, nursing in your hospital, talk to radiology, and model it after departments that are already doing it. You know, we talk to our IV therapy team, our cath lab nurses, our ICU team. Ultimately, you know, everyone's really busy. And so it's sometimes a lot to ask, but our cath lab nurses were incredibly helpful in the initial training of a lot of our staff. But this really is so dependent on where you are, your facility, you know, your limitations. At my last hospital, it was a much smaller community hospital. And so implementation of this was so much easier because we had a small lab, we had nuke med right there with like one of the nuke med techs was, I've never seen her miss an IV in my life. And she was like this amazing support person. And we had nursing right there. And so it was so much easier to train in that environment. Whereas now we're at like this really big facility and everyone's so busy. So you really just need to do, you know, what works best for, you know, for your lab and your specific facility. I actually did this completely wrong in the first place, and it's really trial by error, because I first had everyone just training in the cath lab and then being like, okay, well, you know, you're all set. No, because ultimately, you know, repetition is what matters. And, you know, doing a few IVs in the cath lab just wasn't quite cutting it. And so ultimately what I did was have one of my sonographers that is very, very good at IVs spend the entire week for several weeks at our outpatient clinic and just do every IV for every patient with the sonographers, and was there as a resource for any, you know, tough sticks or, you know, and was just consistently there for them. And I found that that worked so much better than just, you know, sending somebody to the cath lab for a day. So steps for IV competency, we first have like an online course that we do, and I'll talk about that in a second. We have like a little didactic session. We practice on the fake arm and then observe IV placement. The fake arm's great. They're really cheap, and it gives you like the motor skills that you need to try to, you know, start doing IVs. If nothing else, you can, you know, beat your coworkers with it. I'm just kidding. We don't promote violence here. But you know, it's a good thing to start with. And then actually inserting the IVs, we do 5 placements before like you're officially signed off. I always let everybody practice on me. I think they like sticking me. But that's the best thing to do, is just practice, practice, practice over and over again. If you think about the first time you did an echo as a student, you know, on a real patient, how nerve-wracking that was, or did any study, not just an echo. And now, you know, it's second nature to all of us going in and doing an ultrasound. So, you know, it's the same thing. The only way to learn is just by repetition and by doing it over and over again and building that confidence in order to succeed. So over the next few slides, I'm just going to go over some of the things that we review during our competency assessments. And so we have this, this is an institutional-wide learning module. So again, I just stole it from nursing and assigned it to my sonographers. And it's probably from 1989, but it just really, I mean, it gets the point across, right? It just goes over kind of the basics, and I'm just clicking through really fast here, but it goes through the basics of what to do, aseptic technique, basics of IVs, how to do a tourniquet, kind of the different tricks you can do if you're having a hard time, you know, getting an IV, things like that. So it's like this online thing that everyone has to do before they, you know, start practicing their IV placement. And believe it or not, applying the tourniquet tends to be something that everyone is very, you know, nervous about and, you know, wants to practice. And that's great. So we have that fake arm, and just start practicing on the fake arm, and then just start practicing on your coworkers and other sonographers, because that tends to be something that, you know, people get nervous about doing. And really, we just try to teach that you want it really tight, and you want to be able to release it really easily with just that one hand, you know, after you place the IV. But this is something that people tend to get hung up on. So I would certainly practice this part as well. And then, you know, understanding our different IVs, our different catheters, knowing that our, you know, smaller gauge needles are bigger, and knowing that, we don't want a needle that's too small because that will affect the integrity of our bubbles. Knowing your basic vein anatomy. This is something that we go over. This is obviously very basic, but we just go over, we want to avoid the wrist. The wrist tends to be very sensitive. We want to avoid, you want to avoid like those tortuous veins, and you want to avoid the valves of the vein and try to find a nice straight vein, something that's easy to cannulate. And you want like a nice, it's not always necessarily like bulging out and visible, but you can usually feel it and feel that it's bouncy and like rubbery and has like that bounce back on it, which is important. When we place IVs, peripheral IVs in the inpatient unit, we tend to avoid that median cubital vein because that's, if they have that IV for a long period of time, it's not the best spot because it's right in the nook of their elbow there. But if we're just using it for contrast for a few minutes, that's a great option. And then really that cephalic vein that runs along the forearm is a great choice because it's easy to stabilize, and it's usually right on the top of the forearm. And then ultimately, just those tips and tricks that we can do. So if you have a tough stick, using hot packs, making a fist, making sure, the arms below the heart, and using your IV therapy team, right? Like 2 attempts, and then, get IV therapy, and then watch them, see what they do, see how they do it, and learn from your coworkers and how they're ultimately able to get the IV. And then, you'll get it, and you'll get that blood return, and all is well. So that's the goal. And like I said, repetition, practice, and everybody is able to get there. This is just a copy after we do all of that stuff, after we go over, do all of our injections, all of our competencies. This is like an online assessment that again goes into like their online learning module, which shows that they were able to master each step of the IV insertion. And we fill this out for each of their 5 patients, just to show from a Joint Commission standpoint that they've achieved every part of that competency. So with that, that's all I have. So I'm going to turn it back over to Maria.
Jess, that was amazing. I'm getting an alert here. Let's see. It was amazing. And I just love hearing how your department is actually living the scope and how you were able to implement that. And you see not only the value of IV training and certifying your students, but the direct impact of patient care and patient management. So it's just amazing. So thank you so much for that information and sharing how you were able to establish that in your department and make that a standard. So moving forward, I suspect that our group today is comprised of a diverse group. Maybe there's clinical sonographers that are joining us today, sonography students, perhaps clinical educators or full-time educators. And I want to start my component here by just asking a question. Why should we want to learn or teach contrast-enhanced ultrasound? And I suspect that wherever you are in your professional life at the moment, this answer may be different for each of us. In the end, we hope that when you leave the webinar today, you are completely inspired to establish your contrast lab in your clinical department and to teach your sonography students, and you will be equipped with methods on how to do exactly that. So when we are looking to explore some answers to this question, let's think about it from a sonographer perspective. So as sonographers, we care for patients, and contrast-enhanced ultrasound has become an important tool that has been answering a variety of clinical application and is used in a variety of clinical settings. Like CT and MRI, contrast-enhanced ultrasound has established diagnostic criteria. So for example, the World Federation and European Federation of Ultrasound in Medicine and Biology have created a set of guidelines for the use of contrast-enhanced ultrasound to characterize liver lesions. And in 2016, the ACR released LIRAD, similar to those that are used in MRI, and they are designed to assist with patient management in patients that have liver masses. Furthermore, contrast agents are not nephrotoxic, so they are safe to use on patients that have compromised kidney disease, where CT and MRI contrast is contraindicated. So clearly, we are providing a safe alternative for our patients. That's exactly what we do as sonographers. Furthermore, from a professional standpoint, what does learning and performing contrast-enhanced ultrasound allow you and provide you? Will provide you challenging and rewarding opportunities to enhance your knowledge, enhance your skill set, and broaden your skill set, and quite frankly, just makes you more marketable. Think of contrast as being its own unique, innovative specialty. So like MSK, like vascular, like MFM, contrast should be considered a specialty like the other aspects of sonography. So for the sonography students that are joining us today, today is really about you. You are the future of our profession. Why should you want to be IV trained and certified? Why should you want to learn contrast-enhanced ultrasound techniques? It too broadens your skill set, and it provides you opportunity to contribute to the healthcare system, or healthcare team rather, in a huge, huge way. So again, makes you more marketable upon graduation. Furthermore, it will prepare you for current day practice. Contrast is used every day and has approval for cardiac and abdominal applications. And big picture, let's think about the future. So researchers are looking for novel ways every day to determine when contrast is applicable, when could it be used to answer a variety of clinical applications. And in fact, when you look at literature, they state that the future of ultrasound may have a more theranostic tool to it. In other words, we have that diagnostic capability, but could we potentially use contrast agents as a therapy to deliver drugs to areas that were otherwise considered privileged? So this is the future of our profession, and you are the forefront of that. So for educators that are joining us today, why should you want to learn contrast and why should you want to teach your students about contrast? Well, it's important that we stay relevant. So we have accreditation standards that we need to meet and maintain. Furthermore, I can think of no better way to enhance student learning experiences than to teach them about contrast. We have credentials that we need to maintain, our own clinical credentials, and we must earn CMEs. So there's opportunity for professional development by attending webinars such as this. And then I always like to say personal growth. I feel like sonographers, we are lifelong learners, and clinical educators, we tend to have one foot in that clinical environment where we need to stay up on current trends and technology that is impacting our profession. But we also need to develop creative ways to deliver content and develop our curriculum to really create those memorable learning experiences for our students. Lastly, I feel like as an educator, we have an obligation. So we have an obligation to prepare our learners so that they are ready to deliver innovative care to the communities they serve. That really is our primary objective and goal. So I know Bev touched base on accreditation, and I have to say that I have to give our friends up north. I'm located in Philadelphia, Pennsylvania, but our friends up north in Canada, you really have it going on, and you really exemplify what can be done, and you see the value and the importance of not only teaching our students about contrast-enhanced ultrasound, but also the importance of IV training and how that directly impacts patient management. So Sonography Canada National Competency Profiles, it is mandatory that cardiac and vascular sonography programs IV train their students. Furthermore, it is mandatory that there must be a didactic component of contrast-enhanced curriculum taught across all sonography programs. So that is part of their accreditation process. That is huge. That is a huge step forward. Here in the United States, things are a little bit different. We have an overarching accrediting body, which is CAHAP. That's what Bev showed us and talked about earlier today. And yes, you will see IV insertion and injection pertaining to contrast-enhanced imaging that is specific to that is common to all concentrations. You will find it under patient management. You will also see contrast-enhanced imaging listed specifically under abdominal sonography as well as adult cardiac sonography concentrations. The JRC DMS. The JRC DMS works in conjunction with CAHAP. They provide recommendations to CAHAP about accreditation. And the JRC DMS houses the National Education Curriculum. And the National Education Curriculum is currently under review. And I will tell you that ICUS, along with many other professional organizations, were part of that review process. And there were suggested revisions that were incorporated, added to that national education part of that review process. The new national education curriculum is set to be released in fall of 2024, and spoiler alert, there were suggested revisions, much more comprehensive curriculum involving not only IB training and insertion, but also contrast enhanced ultrasound in a variety of different concentrations. Because right now, when you look at the national education curriculum, really adult cardiac sonography has the most robust contrast curriculum. But our suggestions were to add it in many different pathways as well. So now that we sort of justified and answered the question as to why it's important that we incorporate and teach and learn contrast to our students and our colleagues, now it is, how can we incorporate contrast into curriculum? And no doubt, there are challenges. We know that there are challenges and obstacles that we face, not only as clinical sonographers, but as sonography educators. So in 2019, ICUS, along with 5 other organizations, surveyed program directors, and they really set out to identify what were the obstacles that were negatively impacting the integration of contrast curriculum. And that survey determined that insufficient expertise and lack of resources are the 2 primary challenges that stood in the way of full integration of contrast curriculum. And I will tell you that we are going to take care of those today. Starting with a very simple question. When you are starting to develop curriculum, the first question you need to ask yourself is, what topics are relevant to your program? In other words, are you teaching future cardiac, vascular, or abdominal sonographers? So full disclosure, I teach future abdominal and vascular sonographers. This is the curriculum. These are the topics that I've incorporated in my abdominal classes. Once you've identified the topics that are relevant for your students to know, then determine in which environment will it be best to introduce this information. You know, perhaps you want to dedicate 1 or 2 special topics classes. Perhaps you choose to pepper it in a variety of different ways, which is what I choose to do. I never want my students to forget about the benefits of contrast, regardless of how you prepare and deliver that content. This much is true. The time is now that we start to integrate contrasts. We must prepare our learners. So before we move forward, and before I start to talk about exactly how you can do that, I think it's important that we have an understanding of what exactly ultrasound contrast agents are. So ultrasound contrast agents are bubbles. They are microbubbles that are comprised of a low soluble gas core. That gas core is an important component because that's what determines the bubble's echogenicity. That gas core is encapsulated by an outer shell. That outer shell is an important component because that's what determines the bubble's stability. So what does that mean for us as sonographers? It means these bubbles are echogenic, they're bright, we can see them, and they are stable. We can image them for a period of time. How do we actually image? How does it work? Well, essentially, these bubbles resonate. They respond to sound stimulation. So the minute that bubble interacts with an ultrasound wave, it reacts. So it begins to expand and contract in response to that ultrasound stimulation. And that's the video that we are watching here. As that bubble is expanding and contracting, it is releasing backscattered signals to our system. We actually call this the dance of the microbubbles. So I need to preface my next few slides by saying some of the ideas that I will share with you, they may not be sophisticated, but I promise you they will be effective. And quite frankly, some of them are they're just fun. Starting with, how can we teach our students the idea of stable bubbles? Why not make unbreakable bubbles? So this is the formula for making unbreakable bubbles. These are just household items that I use. Yes, you do need a glove Full disclosure, this is my old kitchen, but the under cabinet lighting was good for the video, so you make do. So my students play with these in class, and in fact, I have some adult learners in my class that went home and made these bubbles with their children. To teach our students not only the idea of bubble stability, but how bubbles respond to sounds, simply what I did was download a frequency generator app to my phone, and I held that bubble up against a Bluetooth speaker, and I just increased the frequency. And you can watch the bubbles actually vibrate in response to that sound. So next is, how can we teach contrast without having access to contrast agents? And you know, to reference that ICUS survey back in 2019, we know that there are obstacles. We know there are challenges, resources being one of those challenges. But I will tell you that the methods that I'm sharing with you today, I had in the back of my mind. I am an educator. We have like zero capital budget. So it was important for me to develop methods that I knew were possible for our educators and for our programs. And I will tell you that this challenge, or what we perceive to be a challenge, is not really that much of a challenge. So if you don't have access to real contrast agents, you can actually agitate saline. To agitate saline, you need 2 saline syringes that are connected by a 3-way stopcock. This is a YouTube video here for you. I'd like to share with you that's really good. It'll show you how to do that. And you simply push the saline back and forth until the solution is cloudy. And in fact, agitated saline is still used sometimes in some departments, and it really is, I would say, the birth of contrast agents was seeing during an echo a patient that was injected with agitated saline. The images that we are seeing to the right here, the one in the middle, is a base component of a Doppler flow phantom that was injected with contrast agents. The image on the far right is what I refer to as a modified flow phantom. I will get to exactly what that is in just a moment. And that is injected with agitated saline. So it's possible, it can be done. If you have access to a Doppler flow phantom, you will be able to share with your students the impact of focal position on the overall image and how adjusting the overall contrast gain impacts the image. And there are the videos that we are seeing here to the right. To the left is the entire setup of a Doppler flow phantom. But I have to be honest with you. Doppler flow phantoms really stimulate more of an infusion. And what our students will have exposure to is that intravenous bolus injection. So I really want to create learning experiences that my students will encounter in the clinical environment. So my suggestion to you is, don't hook up the entire apparatus of the Doppler flow phantom. Instead, have your students practice doing direct injections right into that Doppler flow phantom. So here we have the base component of that Doppler flow phantom. These different areas that we see here represent different size diameter simulated vessels. And then this was injected, again, this is the base component of that phantom that was injected with contrast agent. Now you may be out there saying, I don't have access to a Doppler phantom, now what? Well, I will tell you, you can create your own phantom. So this is my modified flow phantom. Not sophisticated for sure. These are things that literally were in my kitchen. So here's the formula for creating a modified flow phantom. The clear vinyl tubing will simulate vessel. And just to give you the comparison images that I showed you a moment ago, here is this modified flow phantom. You can see that vinyl tubing, which is simulating that vessel, and this was injected with agitated saline. So it's possible. We can teach these techniques. So we've sort of justified the importance of teaching contrast and how we can overcome the challenge of not having access to a contrast agent. Now we have our next challenge is the lab systems, and at least the system in my lab systems that my students have access to, they're not equipped with ultrasound contrast software. And it's true, you do need contrast software on your system in order to perform contrast imaging. But I will tell you, it is something we can overcome, starting with decreasing the power. So when we image with contrast, the clinical CEUS mechanical index range is anywhere from 0.05 to 0.2. So the images that you are seeing, of course, is that homemade phantom. The image on the far left, that is the homemade phantom injected with agitated saline. However, that output power was the abdominal preset, so it's higher mechanical index compared to the image on the right-hand side, which is my traditional system in my lab, not equipped with contrast software. The only thing I did was drop the power down to 0.2. So you can see the differences in enhancements. These are both that homemade phantom injected with agitated saline. To the left, high mechanical index. To the right, low mechanical index. In fact, that output power, as I mentioned, I just dropped it on that traditional system down to 0.2. So it can be done. Some other important learning strategies that we can share with our students has to do with the effect of depth on enhancement. And when we image with contrast, we are imaging in the harmonic environment. And it's not always that our traditional good grayscale windows translate to a good contrast window. So I want my students to be mindful and to be, quite frankly, creative in placing wherever their region of interest is, try to get it close to the near field. So what you are seeing on the left is one of my bloopers. That was an HCC that was chemoembolized, and we were assessing post-treatment response. So we did our first injection, and that's the image on the top left. I thought I had a good contrast window, but in fact, the window that I chose placed that lesion beyond 10 cm. So we did a second injection, and I was able to optimize my acoustic contrast window. I was able to shut off about 5 cm of depth and place that lesion about 5 cm. So you can see the outcome is greatly improved on that second injection. How can we teach our students the effect of depth on what we see on our image? If you have a standoff pad, I would tell you just place that standoff pad on top of that homemade phantom. If you don't, that's a piece of tofu that I placed right on top of the phantom. So you can see that simulated vessel is around maybe 8 cm compared to you remove that tofu, and you can see that the image has improved. One of the things when I first was learning to perform contrast, one of the things I had trouble adjusting to was that pre-contrast image. So for abdominal imaging, we often use a dual image display, and that's what you are seeing here. And this is a pre-injection image. We have contrast on one side, grayscale on the other. And you can see before we inject, that contrast side is almost completely black, almost completely devoid of enhancement. And that is done on purpose. We decrease the overall contrast gain to suppress the surrounding soft tissue. We really just want to see the activity from the bubble. So how can we simulate this on our traditional system? First and foremost, drop your power. You want to work within that customary low MI range. And then what I'm going to have you do is go into that dual display mode. And I want you to designate one side as your contrast side. So here is our designated contrast side, and then decrease the overall gain until that image appears predominantly black. Then what you will do is have a student inject contrast, and this is what the student will see. This really does work perfectly and simulate that pre and post injection experience that the student will observe. Some additional learning strategies, just talked about the effect that needle diameter has on our image. Our students must know the proper IV setup, and this, what you are seeing here is a setup that we use for abdominal imaging, in which we have a saline flush set up at 90 degrees or perpendicular to our three-way stopcock, and our contrast syringe is set up to flow in a straight direction. So it's important that our students have an understanding of the proper setup when we are performing a contrast study. Furthermore, it's important that our students have an understanding of how to inject. So for abdominal studies, and I will play the video for you, we inject over about 3 to 5 seconds. We start by injecting about 2 cc's of saline flush, followed by the contrast injection, followed by the remaining saline flush. So it's customary for us, and there are a few different injection techniques that you can use and you can share with your students. But this is just a basic understanding of how we inject. We can have our students do this. We can practice this on the Phantom. So I'm going to play this video. As the video is playing, you will see saline followed by contrast, followed by saline. It's also important that our students have an understanding of how they will acquire their images. So they need to maintain a region of interest for a period of time. When we perform contrast studies, we are acquiring cine clips. So we take one long clip, then we stop scanning. We do not do continual scanning. Instead, we will continue to take 5-second clips after injection, every minute, essentially, after injection until the clinical question is answered or until the contrast is dissipated. And you can see how the contrast dissipates the longer we image. So it's important that our students know to avoid transducer dwell time, we do not do continual scanning. It's also important that our students, as I mentioned, know how to inject. So you can inject too fast, and when you do, this is what it looks like. And I have my students inject fast so that they can experience the artifacts that are associated with injecting too fast compared to when you inject over 3 to 5 seconds. And I will have my students actually say it out loud. I say, give them a countdown so that the person who is scanning can operate the system, start the cine clip, start the contrast timer, and then it controls that injection process. Sometimes we unintentionally break bubbles, and to teach our students how that can happen is simply by one technique is to increase the power while the injection took place, and you will see sort of flickers on this image. These still images were acquired from that cine clip. The image on the left, again, is at low power. The image on the right is high power. This happens in real time. For example, if you are in the contrast mode, you think or fear that you lost your region of interest and you go back to your traditional grayscale. Well, what that does is actually increase the power and you will unintentionally destroy bubbles. Another way you can unintentionally destroy bubbles is by placing a color box or the Doppler box on that particular area where the contrast is. So this still image was acquired from that cine clip, and here is where that color box was located compared to directly adjacent to it. You can see that preserved area within that simulated vessel. So this just recaps everything that I talked about today. I really feel like the take-home points really are that you can use a traditional system, just decrease that power. You can use agitated saline to act as your contrast agent. And most importantly, these concepts, these very important contrast concepts, can be taught to our learners with very little tools. So this just sort of breaks down all of the things that I would suggest to you. And I think it's a great initial starting point. Of course, there are assessments, right? So the National Research Council tells us that people learn best when they are interested in the topic, when they are actively engaged in the learning process, and when they apply their newfound knowledge. And I can think of no better way, as I said, to enhance that student learning than to have them experience hands-on experiences to really promote contrast education. So formative and summative assessments, right now, it is mandatory. KHAP and the JRC DMS state that at least adult cardiac sonography students, it is part of their competencies that they need to obtain. They must at least observe a bubble study being performed. In terms of the assessments that I use in my class, a lot of it is observation. And then I also feel like I'm a big gamer, so feel free to scan the QR code. This is what I refer to as bubble bingo. I share it with as many people as possible because everybody loves games pretty much, and my students love it. So that was made with flippity.net. I do want to take a little bit of time to talk about IV training. Just made such a compelling case as to why it's just critical, not only for our sonographers to become IV trained and certified, but really truly for patient management. So I will tell you that our sonography students, as well as CT and MRI students at my institution, they're all IB trained by the time they graduate. This is just a breakdown of our curriculum. We were lucky enough to get our hands on simulated arms. Our lab sciences program provided us simulated arms, and we have assessments that we have established for our students. And here is the thing, and this was key. Our department chair and the dean of our college met with hospital administrators. My institution is hooked up to a big hospital, a big healthcare institute, healthcare center rather. And so they got in the same room together. Our curriculum was shared with them. The hospital administration accepts our curriculum. So essentially, if any of our students graduate and land a job within that healthcare institution, they accept our IB training curriculum. The only thing our students have to do to become fully certified is to do their independent sticks. So we all know that there's huge staffing shortages out there. So I feel like this is definitely one area where we can bridge that gap and be part of that solution. No doubt there are some sonographers and of course some students that I feel like are a little bit nervous to work with needles. One of the things that I've incorporated in my class is just getting my students accustomed to working with needles. So I repurposed that piece of tofu, and this is actually part of my interventional procedures class. Our students have to know how to identify a needle on ultrasound. That's just the primary objective. So what I did was took a piece of tofu, inserted a straw into it, and I just have my students insert needles. So it's all about not only finding that needle path, but more importantly, getting my students accustomed to working with needles and really reducing that fear. I do want to share some resources with you. So first is Northwest Imaging Forums, who are kind enough to provide us a platform for this webinar today. They have a wonderful IB training course already established for you, and this could be used for clinical sonographers where you're trying to get your department IB trained. It could also be used for educational programs. So there is a didactic component where you can earn CMEs, and that's online. And then there's an additional hands-on component where they will practice in person with simulated arms, which is also associated with CMEs. These are just some additional resources that I'd like to share with you. A lot of this has to deal with IB training and specifically geared towards radiology technologists and specifically sonographers. In terms of curricular development, these are some resources that I'd like to share with you. I will tell you that the SDMS Knowledge Series, they just released a contrast lecture that has associated CMEs. Don't forget that ICUS is your one-stop shop for all things contrast. So not only are there resources on the ICUS website available to you to help you establish your contrast lab in your clinical department, but there are also educational resources such as the training hub, which I had mentioned earlier. So within the training hub, as I said, it's divided into two: cardiac component as well as general sonography. Vascular sonography will be found under that general sonography. Feel free to scan the QR code. As I mentioned earlier, ICUS is free membership. All of the CME webinars, they're free. And these resources are available to you for free. So I want to finish up today by just sort of making a comment, and then I'm going to ask you a question at the end. But my comments initially really are, I feel like when you work with contrast, you see directly the positive impact it has on patient management. And I have to say, from a professional standpoint, it just rejuvenates your passion for what you do. So I feel like those that do that perform contrast imaging or are involved with contrast, our community, we are all bubble believers, and we are here to support you. So I would encourage you to reach out to your vendor and bubble manufacturers. Maybe they can come do a lunch and learn for your department. Maybe they can provide you contrast agent or expired agent so that you can practice with your students in your lab. Certainly, I would say consider applying for a grant and perhaps maybe putting contrast software on one of your lab systems. I think a great place to start is reaching out to your clinical affiliates and sort of getting an idea of who exactly is performing contrast. Maybe you can have your students rotate through or at least do a shadow day so that they can experience a contrast study live and in person. Certainly reach out to all of us as guest lecturers. And I'm going to conclude today by really just asking you a question, which is, what do you think the roles and responsibilities of sonographers will be 5 years from now? Or maybe 10 years from now? I feel like we all have a certain view in our mind of how we think sonographers will function in that time. So quite honestly, the students that we are teaching today, they will be practicing 5 years from now and hopefully 10 years from now as well. And I think we can all agree that technology just continues to advance and getting not only sonographers and students excited about learning contrast enhanced ultrasound, it's not only important to the utilization of contrast, as Jess said, but it's also critical to the continued growth of our profession. So with that, we would be happy to answer any questions that you may have about the information we shared with you today. And I have to say, I'm so grateful for the opportunity to share this information, and I'm so happy that you joined us.
Okay, at this time, we're going to start answering some of our questions. Maria, you want to take the lead and directing those to the relevant faculty?
Sure. So I'm just reading the first questions. It says, are we covered to inject contrast? Our physicians do it at their institution. So Jess, I don't know if you want to take that one.
Yeah, I still hear a lot of misconceptions about, there's legality involved with certain states not allowing sonographers to inject. ICUS actually went through this with a fine-tooth comb and looked through for any regulation that may be prohibited where, non-nurses or non-physicians can't inject things, and they couldn't find anything for a state statute regarding that. So it's really determined at a facility level. And that's why I say, we really need to model this after other departments in your facility that are probably already doing this, like MRI or ophthalmology, things like that.
Jess, I'm going to ask you another question.
Yeah.
And it is, if your sonographers are IV trained, do they have a bump in their pay?
So we actually, in conjunction with all the work we've done regarding workflow barriers, we recently instituted a sonographer 1, 2, and 3 tiers. And the IV training is not required for the next tier, but it's part of something that can get you to the next tier. So the way we have it structured is that if you have like 2 or more of specific parameters, you can advance to the next tier, and IV training is one of them. And so there is I think between tiers here, we do a 5% bump in pay for each tier. So we have a 1, 2, 3 lead and then technical director. And, there's other things in those tiers besides IV training. If you do research studies or if you cover, cath lab studies, there's different ways you can get to the next tier, but IV training is one of them.
That's great. And 5%, I mean, that's significant. That's a nice bump.
Again, we modeled it after like radiology here, because radiology had sonographers 1, 2, and 3. And so it gave us precedence to go to administration and say, this is something that we should be doing. And, quite frankly, employee retention right now is huge for all of us that are feeling staffing shortages and things like that. So we just wanted to really make sure all of our sonographers know that they're valued and are compensated for their additional skills.
Yeah, that's awesome. So I will take this next question, which is, are vascular ADMS certified techs allowed in the scope of practice change now as well? Yes, that answer is yes. That scope of practice is designed for sonographers. It's people where it's sonographers of all, sizes, shapes, everything in specialty areas that are providing patient care. So again, that scope of practice is what we can and can't do as sonographers. So yes, RVTs are included in that. See. So this is another question. I assume there is reimbursement for using contrast agents. Yes, there are reimbursement charts available on the ICUS website. I will also say reach out to your bubble manufacturers. They can help you navigate that process of billing. Jess, if you wanted to add anything about billing and how you established your codes.
Nothing really to add. I mean, there's certainly reimbursement. It's a bundled for Echo anyway. I know it's a bundled charge, but you are reimbursed for the use of the contrast.
There's a question here. Is there any reason why we shouldn't use DEFINITY on a patient? Example, chronic kidney disease, any allergies that would relate to reaction to contrast. So right now, contraindications to ultrasound contrast use has to deal with hypersensitivity to the bubbles components. So in fact, as I mentioned earlier, the contrast agents we use are not nephrotoxic, so they are safe to use on patients that have compromised kidney disease, therefore providing that safe alternative. So that's different, and that's what makes ultrasound contrast agents unique compared to CT and MRI contrast, which has associated contraindications pertaining to kidney function. Trying to go through these. A lot of them, everybody's saying hi. Oh, here you go, Jess. This is a good one for you. How do you handle the sonographer that does not want to learn how to place an IV or inject bubbles?
So that's a great question. So I do not, it's not required. I didn't make it a requirement for our sonographers. I'm not going to force anybody to do it. I have to say that out of every sonographer that I've worked with that has learned IV, nobody regrets it. Everybody loves it, loves that they have that additional skill. And, I have sonographers from all walks of life here. I have sonographers brand new out of school. I have sonographers that have been doing this for like 40 years, and everybody that has come out of it has really appreciated it and really appreciated what that has done for them in their daily workflow. So I would say just like if they're nervous, I think the majority of us are just nervous. It's something new. It's something we're not used to. Just repeat exposure, maybe just like having them tag along with a sonographer that is IV trained today to see their workflow and how much more efficient it is. But ultimately that's why we increased pay, because honestly, money is always the best driver in my experience. So,
cash is king. I also feel like, once you start to see all your colleagues becoming IV trained, placing IVs, they're exemplifying that it can be done. And now hopefully it sort of catches on that just becomes the new norm.
I've always said you have to find a way to take the scary out of it.
Yes, right. Exactly.
And just by, them seeing that their colleagues are comfortable with it, I think most people come around.
So I agree with you, Bev. Definitely take the scary out of it. Start by just sticking needles in, for example, tofu. I also tried Spam, doesn't work as well, and it's a little bit, different in texture, but tofu works well. So let's see, we have questions about insurance providers. Again, I would encourage you to visit the ICUS website to look for additional information on reimbursements. Sorry, the questions are sort of coming in quickly. So is there a way to require that contrast is taught in sonography schools? Given that many instructors may not have experience themselves, how can they develop the competency to teach? Great question. And I hear you. So for sure, there are CMEs, and you will find that, for example, the SDMS knowledge series, they have CMEs associated with contrast imaging and the basic foundational knowledge of contrast. You will find that there are some similarities. For example, when we perform contrast imaging, we're working in the harmonic environment. We all know about tissue harmonics. This sort of functions in exactly the same way, except instead of soft tissue creating those higher frequencies, it's actually the contrast bubble. So a lot of these things, there are similarities across the board. In terms of making it mandatory in schools, I think that's part of the accreditation process, and that national education curriculum that I had mentioned earlier, it's currently under review. So look for that new national education curriculum to be hopefully publicly displayed as of fall 2024, and will include contrast components to it. That really does make it mandatory that we must teach it. And as Bev mentioned earlier in her slides, right now, specifically contrast enhanced imaging is listed. It's just not as detailed as we would like. So look for those newer details to sort of create some guidelines and to help educators as they develop content. Let's see. Oh, somebody made those bubbles with their kids. Cool. Love it. Now just hook it up to a Bluetooth speaker. Okay, so is the information how contrast works available on the ICUS site to use to teach to students? It's good information. I can't see why we couldn't make that available on the ICUS website, but certainly we can get permission for that. And then I have a few questions asking if the recording and the presentation and slides will be made available. So Matt, I think I'm going to defer that question to you, my friend.
Sure, absolutely. Yeah, and that is true. The recordings you'll find on the ICUS website, as Maria's been mentioning through the presentations, there's a wealth of information there, and you'll find previous webinars, including this one, will be posted as well once it's recorded and just slightly edited, and will be posted there for those ICUS members to review.
Thank you, Matt.
A few questions here about ASC guidelines, if they're going to move away from the 2 continuous segments, or when the next release will be. I don't know, but I will say that the guidelines from ASC in 2018 did expand beyond the 2 continuous segments, and they did say something along the lines of it should be used in any situation where the determination of LVEF is important to clinical prognosis, which is so many of our patients. Bev, I don't know if you want to expand on that at all.
No, that's exactly right. It's, the population is bigger, older, and sicker. And so I just think that just about every patient is going to benefit from contrast, honestly. The other thing, going back to the other question, the Sonographer Resource Hub, I'm telling you, that was a whole group of people that came together and shared all their resources. And when you look at it, and Maria talked about that, it's divided into echo and then general, but there's links to webinars, to papers, to just all kinds of reference. So I think that's a good place to start, just gathering some information. It's a lot.
I'm kind of scrolling through these questions, and Bev and Jess, feel free to shout anything out that sort of catches your eye. But there was a question about, can you inject and scan at the same time? It was not my practice in abdominal. My background is in abdomen, not echo. So typically I was the one that scanned and worked the system, and then somebody inject it. And Jess and Bev, you're in the cardiac world. That's how you operate as well?
We right now, for regular contrast studies, we just do them one sonographer. And because of the way that we wait for the heart to fill with the contrast. You don't necessarily, you don't need to see it in an instantaneous manner. And so having just myself or one of the sonographers do it alone is fine.
Okay.
However,
Cool.
I will say that that kind of resource sonographer that I talked about, resource sonographer position, my goal for that position would be for a person to kind of be able to travel around and help if you do have like a really large patient that you're having a hard time doing both, or just like a tough patient, or you're in the ICU and there's 27 machines and you can't reach over, and just to kind of help in those day-to-day situations as well.
Somebody has a comment. Roles of sonographers are increasingly moving towards diagnosing and taking a more active role, such as injecting and using contrast sonography. Yes, totally agree. And like I said at the very end there, I feel like we can all agree that our roles and responsibilities just continue to expand. And we need to prepare our learners now because they will be experiencing this for sure.
I see a few different questions on safety and administration. I think safety is a whole different talk that we could probably spend another hour and a half on. There are archived webinars, I believe, on the IGUS website about safety that you can find that kind of go through not only safety, but how to prepare your lab in case there is a reaction, and how to handle that, especially if your sonographers are injecting. There's a question here, can it be administered without a cardiologist on site? There has to be appropriate personnel to respond if there is an emergency. And so if that appropriate personnel may not be specifically a cardiologist, but it has to be some sort of medical personnel that can respond to that emergency. And so integrating this at one of my offsite clinics that has no access to like a rapid response team or a code team was a little bit more difficult, because we had to really make sure there was always somebody on site that was assigned to respond in case there was a reaction. It can be done. You just need to make sure that roles are very clear and that there's somebody there that it's in their scope of practice to respond in case of an emergency. Can you use an existing IV for contrast? Yes, that's why I think we see such a higher percentage of use in our inpatients, because they have IVs. And so I would say that you can certainly use an existing IV. You just want to, if you're ever not sure, just talk to the patient's nurse and see what's appropriate to use.
So some of these questions have to do with technique, like bubble destruction techniques and harmonics. And yes, as Jess said, there are many different webinars available on the ICUS website that I would encourage you to look. There's a question about research, or I suppose outside of routine applications. So as I did mention, researchers are looking and exploring every day for when you can apply contrast agents in a variety of clinical settings, one of those being soft tissue and lymphatic systems. So I would say definitely visit the ICUS website to answer some of this information. Our objective today really was to talk about the value of incorporating contrast, not only IV training as well as contrast curriculum within your department and within your sonography programs. There's another safety question about reaction. So here's a question. Do you think CEUS will be required in the future? And if so, when do you think that will be? I will say that that's yes, and the future is now. So I don't know if Bev and Jess, if you want to expand on that, it's used daily, currently. So.
I mean, if you
Absolutely.
say like required from a accreditation perspective or required from a reimbursement perspective, I don't know, but I can say like I wish I could put up here the amount of good quality studies that I did contrast in, that we found so much pathology that later change management. I have a whole talk on it, and it's really quite impressive, these studies that you would have never thought you needed contrast for, that you get such you know, you find all this amazing, not amazing, but you know, these beneficial things. So I think, yeah, I think the requirement it is, we should be required now, but like from a reimbursement or an accreditation standpoint, I think that is probably in the future. I know there are some places that I've done talks at where you walk in as an outpatient, you get an IV and you get contrast for every single study. And so I think we're trending a little bit more that way.
Here's a question. Do sonographers have to be MA? I'm assuming MA is medical assistant as well, or certified before training.
Mm-mm.
No.
Again, institution-wide, you know, you'd have to check your, you know, your hospital policies on these things, but there's no way where that says that should be the case. I see a few questions about doing bubble studies. You know, do sonographers in your facilities do bubble studies? Yes. Our sonographers also do our bubble studies. We do have 2 people for our bubble studies, 2 sonographers for our bubble studies. And that is part of we have a standing order for patients that present with certain symptoms. We automatically would do a bubble, and sonographers are able to do that at their discretion.
Jess, if you don't mind, and Beth, I'm going to share my screen because I'm going to put that QR code back up, and I'm sorry now that I got out of my shared screen. But if you want to scan that QR code to join ICUS, feel free. Sorry, I should have left that up there. I didn't think of it until I'm going through the questions now, and people have asked about that QR code.
Yeah, there's a lot of great information there. That can really be beneficial.
And as an educator, it's free. I love free. Yeah. The best price.
And as Maria went through in the very beginning, there's so many resources, not just the website. There's an app. Once you're a member, again, which is free, you'll get the news monitor, which you get right in your inbox that has all this new stuff going on, and things like that, and case of the day. And I mean, it's unbelievable how much information is available for free.
Right, for free.
Free.
So here's a question. Is CEUS approved by FDA in the US? That answer is yes. So it's approved for cardiac applications. It's approved for abdominal imaging, specifically in adult and pediatric patients to characterize liver lesions, as well as pediatric patients for the diagnosis and treatment response of vesicoureteral reflux syndrome. And it has, there is an agent that is recently approved for pediatric echo as well. And Jess, I don't know if you want to, and Beth, if you want to mention anything more about that. So, you know, the take home point is yes, it is FDA approved in the US.